Hi, I'm Ray Hershberger. I'm delighted to be part of this session on Saturday, July 2nd. I am a professor of medicine, a cardiologist, actually a heart failure, heart transplant cardiologist at The Ohio State University. And I'm pleased to present to you on cardiomyopathy and Titin. So I've been doing dilated cardiomyopathy research for some time, many years actually. The aims are to identify and characterize genetic causes of dilated cardiomyopathy and to translate new genetic knowledge into the practice of cardiovascular medicine. Our website here is shown at the bottom, www.dcmproject.com. There's a lot more information about dilated cardiomyopathy and genetics if you'd like to look at that. So what is dilated cardiomyopathy? Dilated means enlarged. Cardiomyopathy, the cardio part means heart, the myo means muscle, and the opathy means disease. So dilated cardiomyopathy means heart muscle disease. And along with that, there is a heart chamber enlargement. So let me start off with some very basic things. What is the heart? You know that the heart is a blood pump. And its job is to pump blood to the body, and it has three main parts. The heart muscle, of course, to do the work, an electrical system to keep the beat, and blood supply to nourish the heart muscle. Now, the medical terminology for these three parts, the heart muscle, we call that myocardium. An electrical system, we call that the conduction system. And the blood supply are the coronary arteries. There's also heart valves, I'm not going to discuss those, and also nerve connections and other parts of the heart, but at least for simple purposes, it's these really three things. So this is a picture of the heart. I hope you can see my pointer. The blue side of the heart here receives blood from the body, back from the body, the blue blood or without oxygen. It is sent from the right ventricle to the lungs. The lungs exchange carbon dioxide for oxygen. That comes back through the pulmonary veins to the left side of the heart, the left atrium, into the left ventricle. The left ventricle is the major work part of the heart. It opens, accepts blood, squeezes out a lot of blood into the aorta, which is the main artery. The aorta, of course, provides blood to the head and also to the rest of the body. So the heart also has an electrical system. We call it the conduction system. And literally, you can see that the SA node up here at the top of the heart is what starts the heartbeat. That is connected down to the atrioventricular node, or this switch box here that then puts a delay in there and then conducts the electrical activation down to the ventricles to cause the synchronous contraction of the atria on top and then the ventricles below. And finally, the heart is a muscle, and it needs blood supply and oxygen also, and it has its own blood supply. Those are called the coronary arteries. They come out of the root of the aorta, shown here in this artist diagram. There are two main coronary arteries, the left and the right. The right provides blood supply mostly to the right ventricle. The left coronary artery provides blood supply to all of the left ventricle, some of the right, and as you can see shown here. Now this is a beautiful picture showing this feathery blood supply to the heart muscle well beyond the major coronary arteries. And this is, of course, critically important for good heart function. Now this shown here is a blockage in a coronary artery, again an artist's depiction of that. And that coronary artery blockage is what causes a heart attack. When that blocks off completely, the heart muscle cannot get blood supply, cannot get oxygen, and causes a heart attack. If the heart attack is severe enough, it can cause an ischemic cardiomyopathy. Ischemia means lack of blood, lack of oxygen. So with a blockage of a heart artery, the ischemic injury causes literally the heart muscle to die, and with severe heart muscle loss, this will cause an ischemic cardiomyopathy, or heart muscle disease from ischemic cause. Now, coronary artery blockage is the most common heart disease, and it does result from atherosclerosis, but importantly, that is not what we study, and that is not relevant to Titin cardiomyopathy, because Titin cardiomyopathy is not caused by heart attacks, just Again, this is a common question of, gee, is this caused by cigarette smoking and heart attacks and all of that? And the answer is no. I'll come back to Titin, of course, for you through the talk. So dilated cardiomyopathy, again, we consider it a normal-sized left ventricle. The left ventricle, again, the major chamber that does most of the work, with some myocyte injury, could be heart attack, could be genetics. The heart muscle, the left ventricle dilates up, tends to thin out, and has contractile dysfunction. Now, what is contractile dysfunction? Let me show you what that is. This is the normal left ventricle, and with each beat, it squeezes out most of the blood. And I can actually, that amount of blood being pumped out is called the ejection fraction. That ejection fraction is normally 55 to 65% of all blood in the left ventricle when it's full. And this other heart here is a dilated, enlarged left ventricle compared to the normal left ventricle. And when it contracts, the amount of blood it pumps out is less than the normal heart, even though there's a much greater volume in that dilated left ventricle than the normal ventricle. We call that dilated cardiomyopathy. That reduced ejection fraction in the DCM heart is compared to the normal heart. That ejection fraction is called the left ventricular ejection fraction. Sometimes with advanced disease can be in the 10-20% range, whereas this normal ventricle has an ejection fraction of 65%. So we study DCM so that we can prevent advanced disease. Now, advanced disease, I'm a heart failure transplant cardiologist, so I know heart failure, arrhythmia, and embolus. They cause a lot of morbidity. Morbidity is the medical term that means illness or sickness, and mortality, of course, is death. We do have drugs, wonderful drugs, devices, including pacemakers, and we also have mechanical support. Those are the heart pumps that can be put in to support advanced heart failure. And of course, transplant. Transplant is a wonderful intervention, but it also causes enormous impact on patients and families, and of course costs a lot of money. Now, dilated cardiomyopathy does not start here with heart failure with late phase disease. It starts in adults at least. It takes months or years to develop dilated cardiomyopathy. And of course, in most adults, we think the heart starts with normal heart muscle, but over months or years, it turns into dilated cardiomyopathy and then eventually presents. The key point is that there are no symptoms. Dilated cardiomyopathy and its evolution is asymptomatic until it finally presents with late phase disease. Most of the time it's heart failure, maybe 15% of the time it's arrhythmia. But again, the key point is that patients can have dilated cardiomyopathy. Now, if you screen people at risk for heart failure, these would be family members of a patient with dilated cardiomyopathy, we can find clinical disease, but they have no symptoms. That's because the heart is an amazing organ that can preserve the body's function despite not being normal and have an ejection fraction sometimes down in the 20, 30, 40% range, but the patient is asymptomatic. Of course, risk of disease is about genetics, and genetic information of at-risk family members permits risk assessment by surveillance screening. That would be doing an echocardiogram, an imaging of the heart to get some evidence of dilated cardiomyopathy to try to prevent it. And of course, clinical screening of at-risk family members can permit diagnosis of dilated cardiomyopathy before it actually presents here with heart failure. The idea is to dial in drugs or devices to actually prevent the progression to heart failure, and of course to tend to decrease or even ideally just completely eradicate this advanced disease called heart failure. Now, what's heart failure, you're saying? Gee, so the definition, this is a clinical definition for doctors, a clinical syndrome that results from any structural functional cardiac disorder that impairs the ability of the ventricle to fill or to eject blood. Heart failure is a huge definition that encumbers many different causes, including dilated cardiomyopathy. In plain English, heart failure is a whole body illness with signs and symptoms resulting from any kind of heart trouble that impairs the ability of the heart to pump enough blood to keep the body healthy. It's the body's response to a bad heart. So The archaic term we call dropsy. The term heart failure, though, is not like tire failure, where your car tires. Your heart will not suddenly stop or blow up or have a blowout or perforation. It's a bad term, but it's been what's in the literature for decades, and we're stuck with it. The principal signs and symptoms of heart failure are low flow or reduced cardiac output. The heart isn't putting out enough blood. Most of that is fatigue, no pep, no get up and go, and shortness of breath with exertion. Those are the two principal findings with heart failure. And then eventually salt and water retention, edema, orthopnea, which is the need to sleep on more than one pillow at night, and then something called paroxysmal nocturnal dyspnea. Paroxysmal means sudden onset, nocturnal nighttime, and dyspnea, shortness of breath. So people wake up in the middle of the night, short of breath, have to sit up at the edge of the bed for 5 or 10 minutes to let the water drain back out of their lungs, because they're collecting lung fluid called pulmonary edema from the edema that's coming back from the ankles and legs into the body as the patient lies down at night. Now, the low flow is the principal and by far the most first symptom of dilated cardiomyopathy. Dilated cardiomyopathy is not heart failure. Heart failure is not dilated cardiomyopathy, but dilated cardiomyopathy can cause heart failure. And by far, this shortness of breath with exertion is by the most common symptom of dilated cardiomyopathy. Arrhythmias are next, but again, far less common. They can also occur, but much less commonly as the first symptom of dilated cardiomyopathy. So, idiopathic, I want to introduce a new term. The medical word that means we don't know what caused it. We don't understand the underlying cause. And so idiopathic dilated cardiomyopathy is the diagnosis when all usual clinical causes, most importantly heart attack causes, coronary heart disease, have been excluded. There are a few other causes, less common, toxins like cancer chemotherapy and valvular disease, but that's usually easy to pick up. We can sort that out. And most of idiopathic, cause unknown, or what historically has been as cause unknown, most of that has a genetic basis. Now, what we study is dilated cardiomyopathy. About half of the U.S. half of the dilated cardiomyopathy, or half of the heart failure population in the U.S. Of reduced ejection fraction is about 3 million people. And we, of course, do a medical evaluation. We sort the ischemic or the coronary artery disease, the heart attack, from non-ischemic cause. And then we sort out these other causes, valvular and drug-induced and congenital and some other rare causes. What's left is this idiopathic dilated cardiomyopathy. Now, that's a lot of cases. That's almost 1.5 million cases in the U.S. And that's what we study. We do know that dilated cardiomyopathy runs in families, and also that if it runs in a family, it's almost certain that it's genetic, and there's a consensus in the medical literature now that if you have familial dilated cardiomyopathy, it has a genetic basis. The problem is that most of what comes into our clinics is non-familial, even if you screen the family members. And the cause of that has been uncertain, and there's been no consensus, so we've been studying all of this, both the familial and the non-familial dilated cardiomyopathy, really for the last 20 years. Our central hypotheses are, this was the study we just published, we don't have time to present that today, but dilated cardiomyopathy, whether familial or non-familial, has substantial genetic basis. We think it's all genetic. And our next study, big study, an even bigger study, is that there's complexity beyond Mendelian, where Mendelian is one single gene that explains everything within a family. It turns out that it's more complicated. Again, I won't discuss that in detail today. Now, these are the DCM genes, and this is an older slide, just lists of them. It shows all the different categories, the way we classify these different genes, and yes, there is Titin on the list. It's been on the list for a long time. And to make sense of those genes, we did a study with ClinGen, an international group, and actually we here at OSU with Elizabeth Jordan, a wonderful cardiovascular genetic counselor who is my partner in all of our clinical activities. We organized a large group, mostly international. We're very proud of that. In fact, the majority of people were from all over the world, as you can see, all these different countries, and a bunch of wonderful U.S. collaborators too. We looked at all of the genes in dilated cardiomyopathy and assess the evidence, their medical and scientific evidence of their relevance for dilated cardiomyopathy. And this is the results in one slide. I won't go through all the detail of this. Again, Titin is on the list, and importantly, in this definitive and strong list, again, Titin is on the list. So Titin has abundant evidence that it is highly relevant for dilated cardiomyopathy. The other fact, and of course of importance to this Titin conference, Titin is the most common genetic cause of dilated cardiomyopathy. Now, Titin rare truncating variants. A truncating variant, when a gene is making a protein, sometimes it just adds what's called a missense variant, changes one amino acid, but a truncating variant actually stops the protein production at that point. And these Titin truncating variants account for 10 to 20% of idiopathic dilated cardiomyopathy. It's well established in the medical literature. Most of these other genes that I showed on the previous slides account for 2, 3, maybe 4%. So Titin is by far the most common cause of dilated cardiomyopathy. Now, missense variants, changing one amino acid, do not appear to be relevant for dilated cardiomyopathy. This is getting into complex genetics, and I know that Jennifer Roggenbuch, one of my faculty members in the Division of Human Genetics, a friend and a colleague, and a very, I'm sure you know by now, a very talented genetic counselor, of course, dedicated to neurological disease, is there and can explain some of these more important but technical genetic concepts. Now, importantly for this group, Titin cardiomyopathy presents like most other genetic causes of dilated cardiomyopathy. Specifically, there's a wide range of severity of illness that presents. Some Titin patients really don't have that severe of illness. Others present with advanced, life-threatening disease, need heart transplant. That's the way most other genetic causes of DCM present. There are no specific symptoms or signs. When a patient walks through the door, we can't tell that they have a Titin mutation or one of the other 2 or 3 other dozen genes that cause dilated cardiomyopathy. So no specific symptoms or signs for Titin dilated cardiomyopathy. And then I was asked about this. Sarah Foy, who has very graciously asked me to participate with you, said, gee, do we need specific Titin cardiac guidelines? And I don't think so. That's because Titin really is subsumed and included in all the other guidelines, and I'll mention that briefly. Now, Jennifer has really focused on Titin skeletal myopathy. That's, of course, what this conference is all about, and I understand that. Muscular dystrophy and from all different kinds of causes. Titin does cause that, and Jennifer is really an international expert in that. But Titin skeletal myopathy is fairly rare, and then it apparently, at least to me and also in the literature, it's quite rare in association with heart muscle disease. So the skeletal myopathy does occur, and that is pretty rare. And then Titin cardiomyopathy is quite common, but the combination of Titin cardiomyopathy and Titin skeletal myopathy, where the two occur in the same patient, there are a few case reports, but for all the Titin dilated cardiomyopathy we don't see much Titin muscle disease that is skeletal muscle disease at all. It's a very important point for you. Again, Jennifer will discuss this with you, and I'm sorry I can't be available for the discussion because of the holiday weekend and traveling and all of that. Now, this figure is from that circulation paper that Elizabeth and I put together. And this figure illustrates the genetic complexity of dilated cardiomyopathy. And in the outermost ring, we show other cardiomyopathy types: hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy. This is DCM only, and the middle ring shows the genes associated with these different phenotypes or different clinical presentations. Again, this is a little complicated genetics, but I wanted to show you that you can get the flavor from the different colors and stuff. That dilated cardiomyopathy is not just one thing or just one set of types of genes. It's actually different classifications or ontologies. Ontology is the word that means type or grouping of genes, and the ontology classifications for the genes relevant for dilated cardiomyopathy are shown in this inner circle. Sarcomere genes, of course, That's Titin. You can see Titin here and sarcomere. And so Titin is a sarcomere gene, but you can see these other sarcomere genes that are also highly relevant for dilated cardiomyopathy. And again, they tend to present with very similar clinical findings and such. Some of these other genes also really present with DCM only. You can't necessarily tell what the mutation is by people walking through the door that have a genetic cardiomyopathy. Now, SCN5A is a sodium channel that is associated with long QT syndrome, which is an arrhythmia syndrome, and Brugada syndrome. And the arrhythmogenic genes, there are 3 or 4 genes over here. The desmosomes and the SR phospholamban have some more arrhythmia types of presentations, but really in this area here, the sarcomere genes, fairly generic dilated cardiomyopathy. Okay. Let me finish up. I'm going on to 20, just slightly over 20 minutes here. So there are guidelines. I've been privileged to be part of both the Heart Failure Society of America, which is the heart failure cardiology clinical group, and then the American College of Medical Genetics, which is the clinical practice group for geneticists. And this is basically the same guidelines in 2 different publications in 2018, still highly relevant in 2022. These are the guidelines with a new diagnosis of cardiomyopathy, always a family history, family member clinical screening for dilated cardiomyopathy. That's an electrocardiogram, an echocardiogram, an ultrasound of the heart to look at heart function, most importantly, the size of the heart and the function, the ejection fraction, the squeeze of the heart muscle. And then refer as needed, especially for syndromic disease or children. Genetic testing is recommended, genetic counseling for all of the above, and then clinical screening with secondary findings. I'm going to skip that today. And then medical or device therapy based upon what the clinical findings are. And importantly, an implantable cardiodefibrillator. This is the device that's like a pacemaker that can surveil the heart for nasty, fast rhythms and deliver a shock to resuscitate the patient in case they have sudden cardiac death. Again, with bad ejection fractions in high-risk patients, it's important to get those in. This is all fairly generic stuff. Sarah asked me to comment on genetic testing of children. It's only indicated if there's significant risk of the condition with age of onset known in childhood for dilated cardiomyopathy. If there's early onset in the family, we would have no hesitation to grab an echo on a child. But if, on the other hand, if it's later onset disease in the pedigree in the family, we may skip it until the teen years. Reliable tests also need to be available to detect that risk. We have those for cardiomyopathy. It's easy, non-invasive testing. And then useful treatments can be provided. We have those for cardiovascular disease. So again, and then genetic testing, that is doing genetic testing for a genetic finding in a parent, can be done and may be indicated, particularly for early onset disease. It may be important, and we recommend it sometimes routinely. But on the other hand, it should only be done with expert genetic counseling because, again, Jennifer will go through this. Genetic testing should not be done just willy-nilly in anyone for any reason, but only with good thought, with good reason, and again, with appropriate counseling. Okay. So that is it. I'm at 23 and a half minutes, so Sarah said 20 to 25 minutes, so I'm within time. Really like to thank Sarah and the organization for the opportunity to present. Again, questions regarding the genetics and genetic counseling. These are really important issues. Again, you're incredibly lucky to have Jen there with you. And I will defer all of those questions to her. And then wishing you all a wonderful rest of this meeting. And again, thank you so much for permitting me to participate with you briefly. And with that, I will turn the time back over to the organizers. Again, thank you so much.